Hello, welcome to Opioids and Medical Professionals. First, let me introduce myself. My name is Taylor Bybee. I am a health education specialist at South Central Public Health District, and my primary focus is on drug overdose prevention, especially towards opioids. So basically, this slide just states that I am funded by the CDC so that I can do these presentations. However, the CDC gives me complete freedom on what I present, and so these presentations do not necessarily represent the official views of the CDC. Drug overdose deaths have been increasing consistently, and this increase is driven by synthetic opioids. In 2017, there were over 70,000 drug overdose deaths in the United States, and over 47,000 of those deaths involved an opioid. That is over 2/3 of the drug overdose deaths. Another statistic is the drug overdose death rate has increased from 19.8 deaths per 100,000 to 21.7 deaths per 100,000 from 2016 to 2017, and that is close to a 10% increase. Here's a chart that represents number of drug overdose deaths from the year 1999 to the year 2017. As you can see, the death rate is steadily increasing. The death rate from drug overdose has been over triple since the year 1999. This chart represents deaths from an opioid. As you can see, death rates have increased by a large margin since 1999, and the number of drug overdose has multiplied by almost 6 from 1999 to 2017. This chart represents how different types of opioids compare to the death rate. As you can see, since 2013, the death rate from synthetic opioids have increased sharply. Meanwhile, the illicit opioid heroin has increased since 2011, and natural synthetics have increased steadily since 1999. So the statistics in the slides before were the numbers for the United States. So how does the state of Idaho compare? Well, the drug overdose rate was 14.7 per 100,000 for Idaho, when the United States was 21.7. So Idaho is statistically lower. In 2017, there were 248 drug overdose deaths. The total number of drug overdose deaths in Idaho in 2018 was fairly stable compared to 2017, when there was 241 deaths, so a pretty small increase. This map shows a comparison of different states for drug overdose rates. As you can see, Idaho is lower than the national average, as well as the nearby states Oregon, Washington, Montana, and Wyoming. However, the states Nevada and Utah are about average compared to the rest of the other states. This is another comparison of drug overdose deaths between different states. As you can see, Idaho is not the darkest color, but we aren't the lightest either. Idaho is lower than the nearby states Nevada and Utah. We have close to the same rate as Washington, but we are higher than Oregon, Montana, and Wyoming. So the state of Idaho could definitely improve with drug overdose rates. This graph represents drug overdose deaths in Idaho for different years. Drug overdose deaths has been steadily increasing, and drug overdose deaths from opioids have also been increasing as well, and almost tripled since 2004. So what can prescribers do to help lower these numbers? One way is to reduce the risks during opioid use. By reducing the risk, the likelihood of addiction and overdose decrease. The first way to reduce risk is to educate the patient about the risks of opioids. The risks of opioids can include addiction, overdose, pregnancy complications, and possibly death. It is also important to mention the side effects, such as sedation, constipation, and respiratory depression. This way patients know how important it is to be safe with opioids and to protect themselves. It is also important to check with Idaho PMP before you prescribe opioids. This is important because it'll prevent patients from receiving opioids from multiple prescribers, as well as preventing a high total daily dosage and concurrent prescribing of opioids. It is also important to encourage safe disposal of prescriptions so that prescriptions aren't abused later. Please consider displaying rack cards with take-back locations in your area. If you're interested in some, then you can contact me and I can provide some. Also be familiar with the CDC guideline for prescribing opioids for chronic pain. I can provide a booklet for these guidelines and other useful information about opioids. You can contact me if you would like some. There have been some providers that have misinterpreted the CDC guidelines for prescribing opioids in the past. To add clarification, the guideline was written for chronic pain in primary care settings. It is not the recommendation for pain from cancer, surgery, acute sickle cell crises, or palliative care. The guideline does not recommend hard dosage limit, sudden discontinuation of opioids, or abrupt tapers, as this can cause the patients to look for opioids from a different provider and possibly through illegal methods. To help with healthcare providers that are considering a dosage reduction or discontinuation of opioid therapy, you can visit a guide called Guide for Clinicians on the appropriate dosage reduction or discontinuation of long-term opioid analgesics. It can be very beneficial to use the Idaho PMP, which stands for Prescription Monitoring Program. This program is beneficial as it can prevent people from getting multiple opioids from different prescribers. The Idaho PMP is an electronic database that maintains data on all Schedule 2 to 4 controlled substances and opioid antagonists dispensed in Idaho or shipped from a mail order pharmacy to an Idaho resident. Idaho PMP exchanges data with 30 other states, including all surrounding states except for Wyoming. This way, practitioners will know if patients have medications from other states. The database can be accessed by authorized users through a portal or through software that can be integrated into compatible electronic medical records. Registered delegates of practitioners and pharmacists can also access the database under the respective practitioners or pharmacist supervision. One of the best ways to prevent opioid misuse is to minimize the patient's exposure to opioids. The first way is to consider other forms of pain management that isn't an opioid prescription, such as acupuncture, exercise, massage therapy, and physical therapy, as well as over-the-counter medications such as acetaminophen or ibuprofen. Another way to minimize exposure to opioids is to prescribe the lowest effective dose for no longer than the expected duration of pain severe enough for the required opioids. Usually 7 days is the highest that will be needed. Also refer to a specific guidelines for recommendations regarding appropriate dosing of opioids, especially after common procedures. For example, if someone has a toothache, refer to a guideline from dentists. There are also methods to decrease risk of overdose death. One thing to do is to educate patients about factors that increase the risk of opioid overdose, such as higher dosages, combining opioids with sedatives or alcohol, having certain medical conditions, or history of overdose, substance use disorder, or mental health disorder. You can also minimize high-risk prescribing, such as being cautious when increasing dosage above 50 mme a day, and try to avoid increasing dosage to above 90 mme a day. Also avoid concurrent prescribing of sedating medications. It is also recommended to prescribe naloxone to patients at high risk of overdose, as naloxone can temporarily reverse an opioid overdose and possibly save a life. Consider tapering on a case-by-case basis to help ease someone to go off of opioids instead of stopping suddenly to avoid withdrawal. Co-prescribing naloxone to people struggling with opioid use disorder can be beneficial in case an overdose occurs. It is recommended to strongly consider offering naloxone to patients who are prescribed opioids and have any of the risk factors that were mentioned before. It is also recommended to offer naloxone to patients at high risk of experiencing or responding to an opioid overdose, such as individuals that use heroin, illicit synthetic opioids or misuse prescription opioids, are receiving treatment for an opioid use disorder, or have a history of opioid misuse and are released from incarceration or controlled setting where tolerance to opioids have been lost. It's important to note that in the state of Idaho, naloxone can be prescribed to any person with a valid reason to possess it, and the prescription does not have to be intended for the person's own use. For example, someone may be seeking naloxone because their family member is using opioids. There are ways that you can help someone with opioid use disorder. The first is to discuss concerns with the patient and screen for opioid use disorder. One method available for screening is on Module 5 of the Idaho Provider Toolkit. If you do not have one, you can contact me with your email and I can provide you one. If a patient meets criteria for opioid use disorder, offer arrange medication-assisted treatment. Also, please consider taking training and obtaining a Data 2000 waiver to provide office-based treatment with buprenorphine. Echo Idaho provides a free training to become certified so medical professionals can be able to do medication-assisted treatment. It is important to reduce stigma around opioid use disorder, as that is a potential barrier for those struggling with opioid use disorder. Stigma is an attitude or belief that is socially discrediting. Stigma is thought to be a major barrier for individuals seeking help for substance use disorder. The SAMHSA estimates that in 2018, 21.2 million people needed substance use treatment. However, only 3.7 million received that treatment. There are 4 factors that contribute to stigma associated with opioid use disorder. The first is a misconception that opioid use disorder is a willful choice, not a disease. The second is the separation of addiction treatment from the rest of the healthcare system. The third is language that perpetuates the stigma related to opioid use disorder and treatment. The fourth is the failure of the criminal justice system to defer to medical judgment in the treatment of opioid use disorder. So what can healthcare providers do to reduce stigma? The first way is for providers to educate themselves and their staff about the nature of addiction, as well as promote the understanding that opioid use disorder is a medical illness. It is also beneficial to adopt accurate, non-judgmental first-person language, such as avoiding the words addict to describe a person, and instead say a person with substance use disorder. Finally, please consider becoming a MAT provider so more patients will have the option to receive evidence-based treatment for opioid use disorder within primary care clinics. If you have any questions, then please feel free to contact me at my email, or you can call me at the number below. Also, if you watch this video, then please fill out the survey in the description, as that helps me know what you learned and how I can improve. These are the references that I used for this presentation. Feel free to use them if you want to discover more information. Thank you for joining me on this presentation, and I hope you have a good rest of your day.